Thank you, Arti. Hi, everybody. Hope you guys are all doing well in these trying times and trying to make the best of where you are and how you are. Are you guys all able to see the PowerPoint presentation?
Yes.
Okay, great. So I'm going to do a 15 to 20 minute talk on MR imaging of rectal cancer. For those of you that read a lot of rectal cancer MR, you know this is a broad topic and tough to cover in 15 to 20 minutes. I'm going to focus just on the initial staging of rectal cancer, not the post chemoradiation imaging. So I have no disclosures. So this talk was one I gave at last year, the 2019 SCBTMR/SABI conference. So you may have seen some of these images, but we're going to talk about rectal cancer management, normal rectal cancer and rectal anatomy, the protocol that we use for rectal imaging, and then how we actually stage rectal cancer with MR, and then one last slide on the reporting template. So rectal cancer management is based very much on the local stage of the tumor. And what do I mean by that? Well, you know, the two real management strategies include the excision, which is total mesorectal excision, plus or minus chemoradiation, depending on the local stage. So if you have a tumor that is local stage T1 or T2 without any nodal disease, that patient goes straight to resection or TME without preoperative or without neoadjuvant chemoradiation. But if you have stage T3 or T4 or any nodal disease, N1 or N2, that's considered a locally advanced rectal cancer, and those patients get pre-op chemoradiation or neoadjuvant chemoradiation before going to excision. That's a very sort of a simplified algorithm that's followed in the US. It's a little bit different in Europe, a little bit more complicated, but this is for the most part what we do here in the US at this time. So the real crucial part of this is staging. Local staging is important, and MRI plays a huge role in that. So in order to stage rectal cancer appropriately with MRI, we really need to know the anatomy of the rectum. And what do I mean by that? I mean the cross-sectional anatomy of the rectum. So we really need to know the layers of the rectal wall. So the innermost layer is the mucosa, and then followed by the submucosa, and then this thick band that's typically dark on T2, which is the muscularis propria. And then surrounding the muscularis propria is the mesorectal fat in blue, and surrounding that is the mesorectal fascia. So these are important layers to keep in mind as we stage rectal cancer on MRI. Now you'll notice this is an axial oblique T2 weighted image. You may wonder what that is. Well, that brings us to the rectal cancer MR protocol. And this protocol is available on the SCBTMR or SABI website. There's also a protocol available on the SAR DFP website for rectal cancer. They also have a great resource there. So we start with sagittal and axial T2 weighted images. These are typically fast spin echo or turbo spin echo images. And then we want to perform imaging oblique to the image of the tumor, to the plane of the tumor itself. So we do axial oblique. And what do we mean by that? We actually take a plane that is perpendicular to the tumor, which provides us the axial oblique image. And you can see there, what we're looking at is a cross section through the bulk of the tumor there. And then we do similarly a coronal oblique image, which is in a plane parallel to the tumor on the sagittal image there. And there you can see the coronal oblique image. So the utility of both of these axial and coronal oblique planes is to really give you a good cross-section through the tumor along the cross-section through the walls of the rectum and provide a relation and tell you about the relationship of the tumor to that wall. And as we go through, I'll show you examples of how that'll help us with the actual T-staging. We also perform diffusion-weighted imaging routinely at our institution. This is actually more useful in the post-chemoradiation imaging, which we actually will not go into today, but I'll show you some examples of diffusion-weighted images in the initial staging as well. I have there in gray the pre and post-contrast T1 weighted imaging. Typically, this is not recommended by the SAR DFP, and we do not do these, especially for the pre-chemoradiation cases. Sometimes we do in post-chemoradiation, but that's a different topic that we won't cover today. But in general, these are not required, especially for initial staging. Rectal cancer staging can be done on 1.5T or 3T. We use surface pelvic coil, not an endorectal coil. Patients are imaged in supine position. And then depending on your institution, you may or may not use a bowel prep such as a microenema, intrarectal contrast, or a spasmolytic agent. Now, we have recently started using intrarectal contrast, and we've found some utility in it. We've always used glucagon, and we do have the patients administer a microenema before they come. So take home here is really the important part of the technique is these high resolution axial and coronal oblique T2 weighted images. These should be no more than 3 millimeters in thickness. And then as we go through the actual MR staging process, there's a number of parameters that we have to describe, and these are listed here. I'm not going to go through each one, but as I go through the talk, you'll see each one of these described. So the first thing is the location of the tumor, and this can be described as an upper, middle, or lower rectal tumor. The rectum is generally considered to be about 15 centimeters long from the anal verge, and so if you divide that into thirds, you can kind of gauge if the tumor is in the upper, mid, or lower rectum. So we give a general description of the location, and then we actually measure the location and the distance from the anal verge. So we see the anal verge down there, and so you would measure up from the anal verge the distance of the inferiormost aspect of the tumor. We also measure the distance of the inferior aspect of tumor from the anorectal junction, the anorectal junction being obviously higher than the anal verge. And then finally, we measure the tumor size, and that's measured in a single craniocaudad maximal length of tumor. Then we talk about tumor morphology, and what do we mean by this? Well, a tumor can be semi-annular like this. It can be annular where it's completely circumferential, and it can be polypoid. So polypoid obviously is like it's got a stalk, and it's a bulk of the tumor is in the form of a polyp, intraluminal polyp there. So these are variations in morphology of the tumor. In addition, we can describe if a tumor is non-mucinous, so it's got this intermediate signal intensity on T2, which is typical of a non-mucinous rectal tumor, or mucinous, which is moderately hyperintense on T2 weighted images, such as this middle tumor here. And so the one in the middle is mucinous, the ones on the ends are non-mucinous. And this is important because mucinous tumor generally has a much poorer prognosis than non-mucinous tumors. So why would morphology matter? What I like to teach our residents and fellows is really the morphology, in addition to describing the tumor to the surgeon, actually helps you find the area which tends to be the most invasive component of the tumor. And so if you look here, this is kind of a semi-annular tumor with the edges of the tumor kind of seen here at the right anterior and right posterior aspect of the tumor. And so once you know where those edges are, if you look directly opposite from that area, that's where the invasive component of tumor is most likely to lie. Okay, so what I teach our residents and fellows is look for those look for those rolled edges, and then opposite from there is where you want to look for the invasive component of the tumor. So it can help you in that way. So for a polypoid tumor, typically the invasive component is going to be at the base of the polyp. So morphology helps you not only describe to the surgeon, but also for you to help identify the most invasive component of the tumor. So the local T stage, obviously, as I mentioned, determines management and need for preoperative chemoradiation, but also is a prognostic indicator and determines the rate of local recurrence. The T stage on MRI, the accuracy is only about 85%. So it's not the best, but you know, it's sort of the best tool we have, because the prior to MR, endoscopic ultrasound was used, but that was good mostly for T1 versus T2 stage, not extramural extension. So the local T stage, as I mentioned, is determined when you determine the relationship of tumor relative to the walls of the rectum. So here we have a tumor that is confined to the mucosa and submucosa. So this is a T1 tumor. This tumor here is involving the muscularis propria, but not going past it. So this is a T2 local stage tumor. And then if you have a tumor that's extending past the muscularis propria into the mesorectal fat, now that becomes a T3 tumor. And the T4 tumor will involve either the visceral peritoneum or any adjacent organ. So that's a T4 tumor. So the important distinction here is a T2 versus T3. T1 and T2 are treated with surgery alone, total mesorectal excision. T3 and below, T3 and T4 are treated with neoadjuvant chemoradiation followed by excision. So our job as radiologists really is to differentiate T2 versus T3 tumors on the MR. So let's look at some examples. So here's a coronal oblique image through this tumor. And if we magnify this, we look at it, we can see that this outer coat is the muscularis propria, it's intact. This tumor is involving the mucosa and the submucosa. So this is a stage T1 with intact muscularis propria. This patient goes straight to excision without chemoradiation. How about this tumor here? So this tumor actually involves the muscularis propria. You can see the muscular propria is gone, but there's no extension past the muscularis propria. So this is a stage T2. Again, patient can go straight to resection without chemoradiation. In comparison, this tumor here, so the way we describe this is a semi-annular tumor with the invasive component extending past the muscularis propria. You can see this sort of defect in the muscularis propria and tumor extending out into the mesorectal fat. So this is a stage T3. And MRI is better to define stage T3 than endoscopic ultrasound. And based on this finding, the patient in the US will get neoadjuvant chemoradiation and then go to resection after that. This is another example of a stage T3. This is that mucinous tumor, the circumferential mucinous tumor I showed you earlier. So the dotted line, as you can see at this juncture here, is disrupted with this kind of extramural extension of tumor. Similarly here. So these areas are sort of defects in where you expect the normal extension of the muscularis propria with tumor extending outside. So with these mucinous tumors, it can be tough to see the extension beyond the rectal wall. What you're looking for is you're actually looking for the defect of that muscularis propria because this hyperintense tumor may be very similar to the surrounding fat. But this is a stage T3 tumor. Patient will get neoadjuvant chemoradiation prior to resection. And here's an example of that T3 I showed you earlier. Here's an example of how diffusion images can be helpful. So we have this, again, semi-annular appearance with restricted diffusion. And not only do you see it in the bulk of the tumor, but you also see that restricted diffusion confirming that the abnormality outside the proper rectum, in fact, is tumor with the restricted diffusion. So once you determine that this is a T3 tumor, then you want to report what's called depth of extramural invasion. And this is a radial measurement outside from basically measuring out from the muscularis propria to the most peripheral extent of tumor, okay? So here's an example here. The muscularis propria is in that location and we're measuring out to the most peripheral portion of the tumor. Here's another example here. If we were to extrapolate where the muscularis propria would go, it would look like that. And then you want to measure out from there to the most peripheral extent of tumor. And why is this important? Well, we can substage T3s into T3A, which is less than 1 millimeter beyond the muscularis propria, T3B, which is 5 millimeters or less beyond the muscularis propria, compared to T3C and D, which, as you'll see, are 6 to 15 millimeters and over 15 millimeters beyond, respectively. And the reason this is important is because really it's an important prognostic indicator. Cancer-related 5-year survival is 85% in T3A or B tumors and 54% in T3C or D. So much so that in Europe, T3A and B, these tumors, which are less than 5 millimeters beyond the muscularis propria, they're treated in the same manner as T2 tumors, T2 and T1 tumors in the US. They go straight to surgery, and they've found very similar survival and recurrence rates in those patients that are T3B or below and don't get chemoradiation prior to surgery. So for us, it's very important to report this depth of extramural extension because it predicts survival. Now here's a pitfall when you're looking at tumors. So let's take this large mid-rectal tumor and draw a cross-section, get that axial oblique image, and we're seeing these fine spiculations in the mesorectal fat. And these are just spicules of desmoplastic reaction. You can see that these are very, very thin, nothing nodular about them. So you wouldn't call this T3 based on this image. But then if you take an image down here, now you're seeing this kind of more nodular extension as opposed to some of these more fine reticular extensions. So based on this finding, this is a T3 tumor. Same thing on the coronal oblique image, a T3 tumor based on that nodule of extension. But just solely based on these fine speculations, you would not call it T3. This is an important distinction to make. So I wanted to show this case. And here's an example of a much more advanced mid-upper rectal tumor. You can see it's invading the bladder dome here and also invading the peritoneal reflection with the yellow arrow there. So this is a stage T4B. T4A is if it only had peritoneal reflection involvement. 4B would be if it has organ invasion, in which this one does. So this would be a T4B. Okay, so we've talked about the local T stage. We've talked about the measurement of the extramural extent. Next thing to talk about is the circumferential resection margin. This is defined as the shortest distance of the tumor, of the outer edge of the tumor to the mesorectal fascia. Remember, mesorectal fascia is that fascia that surrounds the mesorectal fat that I showed you in the earlier slide. The CRM is considered threatened if tumor comes within 1 to 2 millimeters of that mesorectal fascia. It's considered positive if it's within 1 millimeter of the mesorectal fascia. The mesorectal fascia serves as a natural dissection plane for the surgeon. So when the tumor is within 1 millimeter, it's considered positive, and the surgeon really needs to know that. And this is again important because it predicts 5-year survival, much lower 5-year survival when you have a positive CRM, and much higher rates of pelvic recurrence if you have a positive CRM compared to when you don't. Now, important distinction here is you must specify if the CRM is positive based on the primary tumor extent or based on lymph nodes in the mesorectal fat or tumor implants that may be separate from the bulk of the tumor actually within the mesorectal fat. And it's been shown that if the CRM is positive because of the primary tumor being that close to the mesorectal fascia, that's a poorer prognosis than if it's a lymph node that's close to the mesorectal fascia causing the positive CRM. So here's the case where this is greater than 2 millimeters, so this is a negative CRM. In contrast, here's a patient where if you were to draw where the mesorectal fascia is, the tumor is sitting right on it, and so this is a positive CRM. Now, lower rectal cancers are, you kind of have to think about them a little bit differently because in addition, so there's no mesorectal fascia down there. Instead, you have to worry about the levator muscles. So there's this separate staging system that was put out by the Mercury group a number of years ago for determining the stage of a lower rectal cancer based on their involvement of the anal sphincter complex. Now, the stage itself, you know, people tend not to report the stage because it can be confusing. Oncologists, medical and surgical oncologists think of stage differently than we do just on the imaging. So instead of actually giving it a stage 1, 2, 3, 4 as was proposed by the Mercury trial, we basically talk about if it's involving layers of the sphincter complex or not. And as you can see here, you're comparing it to the muscle coat of the internal anal sphincter, and then the intersphincteric plane, and then talking about how close it is to the actual levator muscles and external sphincter. And let me show you an example here. So here's a case where you have a lower rectal cancer, but you can see that this muscular coat of the rectum itself is intact, and the intersphincteric plane here is clean, and then you have the puborectalis muscle outside that. Posteriorly here, you can see that this muscle is intact, and on the coronal image, which really is helpful for determining the extent of this tumor relative to the anal canal, you can see that the tumor is confined by the rectal wall. So this is confined by the bowel wall and not involving the muscular coat. So this is what you would call a stage T1, but basically what we would say here is no involvement of the sphincter complex. As opposed to this case here, another low rectal cancer, and you can see on the sagittal image that the tumor has grown through the rectal wall, completely involving the levator plate, and this is the outer sphincter muscle here. Same thing on the left side. On this coronal image, you can see this is the outer wall of the rectum. Tumor has gone through that. This fat is the intersphincteric plane. It's definitely infiltrated that, and also it's infiltrating the levator muscles and the external sphincter muscle here on the outside. So this would be the other extreme of positive involvement of the sphincters all the way through. And this again helps with surgical planning, because if there's involvement of the sphincters, then if the surgeon is considering excision, they would consider an extra levator APR potentially, which is obviously they need to know that beforehand. All right, next thing we want to talk about is lymphovascular invasion. This tends to be undercalled in radiology, and what this is tumor extending along the lymphovascular bundle. It can be contiguous, as is here. You can see the bulk of the tumor here, and you can see similar signal intensity within an expanded vessel extending up from the tumor. So this is pretty straightforward to call. But how about this? This is a different patient, axial image, and you can see a couple of these nodules in the mesorectal fat, and you may be inclined to call these mesorectal lymph nodes. But before you do, you definitely want to look at these on a different plane. And when we look at the coronal oblique plane, we see that this is actually a tumor implant along the course of a vessel. So this actually meets definition of lymphovascular invasion. So you wouldn't call this a lymph node, you would call this a tumor deposit along a vascular bundle, which is, qualifies as positive lymphovascular invasion. So this patient would be called as having lymphovascular invasion. And a lot of people don't think about this as lymphovascular invasion. They always want to look for the contiguous tubular extension of tumor. And so I think that's why lymphovascular invasion tends to be undercalled, but make sure to call this lymphovascular invasion because that's what the definition is. And again, this is important because you have a lower 5-year recurrence-free survival and higher rate of metastases at 1 year. A negative lymphovascular invasion predicts better chemoradiation response, and you can see there the MR tends to have lower sensitivity because of some of the reasons I talked about, but better specificity. All right, how about nodal stage? So, traditionally people have talked about a 5 millimeter cutoff, size cutoff to call involved lymph nodes, but it turns out that that's only, it's very low sensitivity and specificity. So what you want to look for is the malignant morphologic criteria. And what this is irregular borders of the lymph node, heterogeneous signal intensity, or round shape. So if you have a lymph node that's less than 5 millimeters, in order for it to be considered suspicious, you should have 3 morphologic criteria. And then if it's 5 to 8 millimeters, you want to have at least 2 morphologic criteria. If it's over 9 millimeters, it's suspicious regardless of morphology. And any mucinous lymph node is also considered suspicious. I will tell you, and I've talked to other people in practice, if you have a very heterogeneous node, it looks rounded and spiculated, even if it's very small, we tend to call that as possibly a positive lymph node. Okay, so last couple of things here. Structured reporting. We've started using this SAR template recently, and I won't go through the details. This is available on the SAR DFP website, but basically, it divides the report into characteristics of the primary tumor. The T stage has a special section on low rectal tumors where it talks about involvement of the sphincters and what level of involvement. Lymphovascular invasion, the CRM, talks about a section on lymph nodes, and then the impression kind of puts it all together. So it's really a template, and it meets the criteria for the NAPRC. The NAPRC is the National Accreditation Program for Rectal Cancer. If you have not heard about this yet, it probably is going to come to a center close to you pretty soon. This is a American College of Surgeons initiative where they're accrediting various centers, and radiology also has certain requirements where we have to be involved with the multidisciplinary care, and we have to report according to what they call the Ontario template. And that SAR template I showed you has all the elements that are required for this reporting. I don't really have time to go into all of this right now, but if you have questions about it, feel free to reach out to me and we can definitely talk about it more in detail. So I think we covered all these things, and in the interest of time, I'm not going to repeat the summary slide, but if you have any questions, I'm happy to answer those.
Awesome.
That was great. There is a question from Sajal. Sajal, do you want to just unmute and ask your question? She wrote in, if there is a 1 millimeter margin of error for the CRM, would you ever actually dictate a T2 tumor, since the muscularis propria is only about 1 millimeter and you may miss microscopic invasion through the muscularis?
Yeah, that's a good question. So as I mentioned to you, this MRI sensitivity specificity is about 85% or so, but it's sort of the best we have in order to determine the extension past the muscularis propria. Now, and the hardest distinction we have to make is that T2 or late T2, meaning full thickness T2 involving the muscularis propria, versus the very early T3. If you have a T3 that's with an extramural extent of 10 millimeters, that's a pretty obvious call. but it's those 1 to 2 millimeter of extension past the musculus propria that's very difficult. Now, the other problem is the second you say this is potentially T3, but you can differentiate early T3 from T2. At least at our institution, the patient gets chemoradiation, and you never know if you were right or wrong. Extrapolating from the European data, where they treat T3A and B, meaning anything with 5 millimeter or less extramural extent, the same as T2 tumors, and have the same survival rates. In fact, in some cases, less morbidity because the patients don't go through the chemoradiation. I try to sort of undercall the T3As. So what I'll say is, if I'm favoring T2 or T3A, I might favor the T2 and just call it a T2 and say this is full thickness T2, knowing that that's about the only way I will find out if I was wrong was if this patient goes straight to surgery, and also knowing that that patient in other centers like in Europe has the same survival as a maybe better in some cases as a T3A tumor treated with chemoradiation. So I'm not sure if that's the right thing to do. I've talked to other people from the rectal cancer DFP about this, and some have similar thoughts. Some tend to say, the second you can't tell T3A from T2 apart, you call it T3A. And depending on your relationship with your surgeon, that's something you probably want to talk about. But that is a known limitation. It's hard to tell the 1 to 5 millimeter extension sometimes past the musculus propria.
Awesome. Any other questions?